So this module is all about abdominal aortic aneurysms. Within this module, we'll go on to talk about the anatomy of the abdominal aorta, as well as the morphology of different kinds of aneurysms. Going on more specifically about abdominal aortic aneurysms, we'll look at the presentation and investigation of them, alongside some of the national screening techniques and the follow-up screening techniques that we can use for patients that have been found to have AAAs. We'll look a little bit about the different surgical interventions that we can use in the emergency situation of a ruptured AAA, and then talk about the post-operative complications that can happen. We'll finish off the module by looking at a few other sites in the body where aneurysms occur, and then do a brief recap of aneurysms. So the abdominal aorta is the largest blood vessel of the body. It enters the peritoneal cavity at the level of T12 through the aortic hiatus of the diaphragm and runs in the retroperitoneum paravertebrally, and as you can see in the image on the right, in very close proximity to the inferior vena cava. It runs down inferiorly until it bifurcates at the level of L4 into the iliac vessels, but you can see from the image that there are a number of different vessels alongside that. And it's quite helpful to split them up into anterior and lateral branches. So the anterior branches of the abdominal aorta are the celiac, superior mesenteric, and inferior mesenteric arteries that essentially go on to supply everything in the gut. The lateral branches are the inferior phrenic artery, the suprarenal artery, the renal artery, and the gonadal artery that all go on to supply different visceral things within the abdomen. And then we have our four lumbar arteries that branch off at different points along the abdominal aorta to supply the lumbar vertebra directly. The other significant branch that's given off is the most inferior branch that's given off posteriorly at the bifurcation, which is the median sacral artery that goes on to supply the sacrum. It's worth mentioning here as well that at the bifurcation where we have our iliac arteries, these will bifurcate further into our internal and external iliac arteries to supply pelvic contents and then the lower limb respectively. When we talk about aneurysms, we can group aneurysms into a few different ways. One of the easiest ways is by morphology, shown by the picture on the right. So we can have fusiform aneurysms where we have this equal dilation of both sides of an artery, or equally around the entire circumference. Or we can have a saccular aneurysm, where there's a dilation in the walls of the aneurysm, but essentially more in one focal point than all around. What we tend to find in real life or with AAAs is that you get this mixed presentation or mixed morphology where you have saccular and fusiform components. So you end up with this large, irregular, globular shape to the artery. The last image on the right is shown as a pseudoaneurysm, where you have this very isolated focal dilation of the arterial wall. And this brings us nicely onto the second way of classifying aneurysms, true or false. The fusiform, saccular, and mixed aneurysm all have equal dilation of all three arterial walls, creating the aneurysm itself. And this is the definition of a true aneurysm. Whereas a pseudoaneurysm is a type of false aneurysm, where there is a dilation of an arterial wall, but not involving all three layers. In the case of a pseudoaneurysm, what we find is that the tunica adventitia, or the external fascial wall of the artery, has become dilated and pushed out by blood flow leaking from the intima and media. And what happens is that as this blood flow collects, it causes a dilation around the artery, and this is the pseudoaneurysm. Common causes for this are needle stick use, so intravenous drug users may present with pseudoaneurysms. And we can also iatrogenically cause it with interventional cardiology or interventional radiology, where we use instruments and tools to access distal arteries so that we can gain access to more central structures. And the way that we manage false aneurysms, we try and operate a conservative approach before a surgical approach. So we can place pressure on the aneurysm with an ultrasound probe to see if we can create hemostasis and block off the aneurysm. Failing that, we can use ultrasound-guided thrombin injections to create that coagulative environment and block it off. And if either of those two methods are unsuccessful, we can do surgery to tie off the aneurysm and completely remove it. So moving now on to abdominal aortic aneurysms, which is a type of true aneurysm. Aneurysms themselves are defined as a dilation of a lumen greater than 1.5 times its original diameter. In the case of the abdominal aorta, the normal diameter is 2 centimeters, so anything greater than 3 centimeters is classed as being aneurysmal. And at a cellular level, the way that AAAs occur, although they are accelerated by hemodynamic processes such as hypertension and atherosclerosis, it's a dysregulation of cytokines at a cellular level that cause that predisposition and aneurysmal dilatation. And a key mediator of that is a cytokine called matrix metalloproteinases. So matrix metalloproteinases in AAA patients are upregulated, and this causes a dysregularity in the regulation of elastic components within the arterial wall. And it's that irregularity in essentially degradation of these products that allows the expansion of the aneurysm wall in response to pressure and atherosclerotic disease. As the vessel radius becomes larger, it creates higher pressure within the artery, and as the wall becomes thinner, this creates a larger amount of wall tension and subsequent dilatation. Normally, AAAs are asymptomatic. However, symptoms that we do find in AAAs when they're quite progressive are that people tend to get abdominal pain radiating towards the back, and on examination you can find that they have a pulsatile and expansile central abdominal mass. In a particularly slender individual, you may feel a pulsatile mass, but it's typical for a AAA to feel an expansile mass as the abdominal aorta has expanded laterally in its dilation. In severe cases of rupture, you may also find patients in fulminant hypovolemic shock, where they're quite pale, quite hypotensive, and maybe unresponsive. The ways that we can look at aneurysms or investigate them are with a duplex ultrasound or an abdominal ultrasound. So we can use an ultrasound probe to get an idea of the actual diameter of the aneurysm. We can also look at the hemodynamics in that by using a Doppler element to the ultrasound. The accuracy of ultrasound is relatively good, particularly for surveillance and monitoring. However, for the best and most accurate measurement, we like to go for a CT angiogram. So this is where intravenous contrast is injected into the veins that runs into the arterial system and allows us to not only get an idea of how dilated the aneurysm is, but to see with a full 3D reconstruction the exact morphology of it, which is good for accurate measurement, but also for surgical planning. And depending on the size of the aneurysm and how patients present, we can either look at conservative, pharmacological, or surgical interventions. So this is a CT angiogram, which is an imaging technique that we can use to show up the vascular tree. At the top of the image, you can see the ascending aorta leading round into the aortic arch where we have our 3 branches, moving more posteriorly and inferiorly down to our descending aorta, which splits into our thoracic components and then our abdominal components as we get more inferiorly. The 2 orange masses on either side of the image are the kidneys being perfused by the intravenous dye. They show up quite well because of all of the small fine arterioles that are within the tissue. The irregular globular-shaped mass that you can see in the middle of the image is the actual aneurysm itself, leading down into the iliac vessels. The location of the aneurysm in relation to the renal arteries is an important thing to note. 70% of all abdominal aortic aneurysms occur below the level of the renal arteries, infrarenally. Other places that they can occur are at the level of the renal arteries, juxtarenally, or above the level of the renal arteries, suprarenally. In the UK, we're quite unique in that we have a national screening process for AAAs. And in terms of the cost effectiveness and cost benefit ratio, we screen men over the age of 65, as epidemiologically they are the group that's most at risk of having an asymptomatic AAA. So what that essentially means is that screening is not routinely offered to women or men under 65. However, if you do have a positive family history or you are particularly concerned and your clinician feels that it's indicated, then you could have an abdominal ultrasound to investigate. Depending on the size of an aneurysm that's been found, essentially determines how regularly you're followed up or whether you need any intervention or not. The threshold for operating is 5.5 centimeters. So if you're found to have an aneurysm that is less than 5.5 centimeters, then you'll be invited back to follow up. So if your aneurysm is greater than 3 centimeters, but less than 4 centimeters, then you will go on 6-month follow-up. However, if your aneurysm is greater than 4.5 centimeters, then you will initially be invited back for a 3-month follow-up scan, subsequently then a 6-month follow-up scan. And this is essentially to gauge how quickly the aneurysm is dilating, particularly if it's high risk, or just to monitor on an ongoing basis. We have 3 main indications for surgical intervention. Aneurysms greater than 5.5 centimeters, as mentioned previously. Any aneurysm with which you're getting symptoms is an indication for treatment, and also any aneurysm growing greater than 0.5 centimeter in a 6-month period. So just to recap that then, if you have an asymptomatic aneurysm and it's found to be less than 5.5 centimeters, then you'll undergo regular surveillance, and you'll also have your cardiovascular risk factors managed medications. So that'll be things like statins to lower your lipid profile, and also antihypertensive medications to manage any hypertension. If a large aneurysm is found, one larger than 5.5 centimeters, you'll be listed for elective repair, and while awaiting your operative date, you'll have your risk factors managed as previously with medications. Regardless of size of aneurysm, if you're getting symptoms with your aneurysm but it's not ruptured, then you'll be listed for urgent surgical repair and also have risk factors managed. The 2 main ways of treating AAAs that we have in terms of surgery are to do an open approach or an endovascular approach. The endovascular approach involves gaining access to the femoral arteries and using endovascular tools to deploy a stent through the aortic aneurysm lining to essentially divert blood flow away from it. And we can also tunnel grafts into the iliac arteries to ensure that we have full blockage of the aneurysm. And this stent is quite similar to the ones used in coronary artery stenting, in the sense that it's a small metallic stent that is self-expanding, that secures itself in the aneurysm neck through radial pressure and secures itself in the aneurysm base, also with outward expanding radial pressure. So this is in contrast to an open surgery, which uses a big midline incision to expose the abdominal aorta, and then an arterial graft, which is the white thing you can see in the middle of the image, is sewn or anastomosed onto the abdominal aorta proximally, and then the iliac arteries distally, and then the aneurysm sac is cleared out of any thrombus and oversewn onto the graft. So what we see in that is still this diffusion of the aneurysm sac by diverting blood flow away. And there are a few things to consider when deciding which approach to adopt. So patient preference is always one. Dependent on the patient age and any perioperative risk factors or how ill they are, then it may be more ideal to go for an endovascular approach, which is more minimally invasive and doesn't carry the big risks of having a big midline scar and the potential risks of an ileus after this from moving all of the intestines around. One thing that's a direct contraindication to an endovascular approach is anatomical risk factors. So when we do a CT angiogram, we get a good view of the iliac arteries alongside the abdominal aorta. And if the iliac arteries are too tortuous or too angled, or they're too narrow, then they may not be big enough or straight enough for the endovascular equipment to fit through. So essentially, if we're not able to fit the equipment through the vessels, it would be inappropriate to attempt it. So an open repair would be a better option. But both options are good for diffusing an aneurysm and for solving the underlying issue. In the emergency scenario of a ruptured AAA, patients will usually present profoundly hypovolemic. So with these patients, it's important to get central venous catheter in, a urinary catheter, an arterial catheter to get full information about not only fluid balance, but blood pressure. And the target blood pressure with these patients is quite low accepted a systolic of 50 to 70. The reason for this is with a ruptured AAA, if you keep the blood pressure quite high, essentially all you're going to be doing is increasing blood flow through this ruptured aneurysm and accelerating blood loss. So initially, fluid resuscitation is quite important, but to maintain a blood pressure relatively low. Excessive fluid resuscitation can paradoxically be quite a bad thing because you can dilute down all of the clotting factors within the body. And these patients will go for emergency urgent surgical repair. AAAs are quite a poor prognosis situation to occur. Even when they occur in hospital, they still carry an 80% mortality. Essentially, 8 out of 10 people with a ruptured AAA will die within 30 days of it occurring, whether that's immediately or in the post-operative period. So emergent management is important and surgical repair is absolutely paramount. And in these cases, surgical repair is usually done open because there isn't usually time to assess them for any endovascular approach. The post-operative complications for AAA repair are pretty similar for most surgical operations. There's always the risk of infection, there's always the risk of bleeding, there's always the risk of DVTs in the post-operative period. Long term, there's the complication that the graft may thrombose or block off if these patients are not medically managed appropriately with antiplatelets. A unique complication to endovascular repairs is that you may end up with a leak around the graft itself. And there are different kinds of those, ranging from type 1 to type 4. With a type 1 endo leak, essentially what we're saying is that the stent is not adequately fitted correctly to the aneurysm itself. So there's a leakage around the proximal or distal aspect, so there's blood flow still reaching the aneurysm sac. A type 2 endo leak is where you have backflow from vessels around the aneurysm sac, and this commonly happens with the lumbar vessels, so you have backflow of blood through these arteries into the aneurysm sac. A type 3 endo leak is usually from a defect in the graft itself and will normally need to be repaired. And a type 4 endo leak is where the graft is quite porous and there's blood leaking through the graft. And this is usually due to over-anticoagulation or a faulty graft. There is acknowledged a type 5 endo leak. Essentially, the classification of a type 5 endo leak is where the aneurysm increases in size and there's no identifiable underlying cause. So after surgery, patients are quite heavily monitored, particularly in open surgery, because of the extra stress on the body. So patients will normally be monitored in a high dependency unit for the initial few days and encouraged to mobilize as soon as they're able to. Full recovery is quicker with an endovascular approach as opposed to an open approach, and patients can return to work relatively quickly. Both sets of patients require CT angiography 30 days after their initial repair to assess whether the aneurysm is still being perfused with blood. And if there is an endo leak, this will then go on to affect the rate of follow-up in endovascular patients. In patients that have an open repair, as long as there's no leakage, then we'll go on to annual follow-up. Initially with a 1-year CT angiogram, and then after this, annual ultrasounds. And these are to assess whether the aneurysm is still expanding, if there's any endo leak, or if there's any thrombosis or any issue with any arterial graft repair. In terms of DVLA guidelines, if you have a small aneurysm, then you're still allowed to drive. If your aneurysm reaches this rate greater than 5.5 centimeters, you need to inform them, but you still may be able to drive if you're undergoing active medical treatment. The major contraindication to driving is an aneurysm of 6.5 centimeters, or if you're an HGV driver, if your aneurysm is greater than 5.5 centimeters. If your aneurysm is treated, the general guideline is that as long as you're able to do an emergency stop, then you can return to driving. We would generally advocate that patients wait until at least a month or so after the perioperative period and their wounds have healed sufficiently before they do drive. Just a quick clinical slide to make you aware that within the body, we can also have other areas that experience aneurysms. So within the brain, you can have cerebral or cerebellar arteries that are aneurysmal, and these can either be clipped or coiled endovascularly. Within the aorta, you can also get aneurysms within the thoracic aorta, and these are operated on in a similar way to abdominal aortas. You can either have an open repair or an endovascular repair. You can get aneurysms within the femoral and popliteal aneurysms, and these are sometimes investigated whenever patients have AAAs. There is an acknowledged coexistence rate of AAAs and FemPop aneurysms. And you can also get carotid artery aneurysms that involve the carotid body, so you can get a dysregulation of blood pressure within these circumstances. Ultimately, any artery in the body can become aneurysmal, but these are just a few interesting clinical ones that you may encounter in literature more commonly than others. And this is a quick slide just to demonstrate this technique of endovascular coiling in brain aneurysms. So you can see in the image on the right, we're attempting to diffuse the aneurysm sac by filling it with a platinum matrix coil, and this matrix coil is coated with prothrombotic material, encouraging coagulation and clotting within the aneurysm sac to prevent blood flow entering it and causing further expansion. So one quick recap of everything we've covered in this lecture. In terms of risk factors, arteriopathic risk factors are also risk factors for aneurysms, the main one being smoking. Symptoms you may experience with aneurysms, commonly no symptoms whatsoever, but you may get pain radiating to the back, and that would be an indication for surgical intervention. On examination, these patients have a large pulsatile and expansile central mass, the keyword being expansile. Investigations, we have the National Screening Programme for an ultrasound scan for males at 65 years old, and then we can also do surveillance with further ultrasounds as needed. Treating these patients, we can gain radical control of their cardiovascular risk factors, in particularly managing their levels of lipids and their blood pressure and smoking cessation. And then we can either do an open or endovascular repair and then monitor these patients long term for any abnormalities or complications that may occur as a result. And in the case of a ruptured AAA, the prognosis is very poor with an 80% mortality. It is a major medical emergency that requires urgent surgical repair. And in the management of these patients, it's important not to give them too many fluids and impair their clotting ability. These are some of the references that we used for this module. I would advise reading them just to gain a better understanding of aneurysms. They're a very interesting and fascinating topic.